Hi there, I'm the neuromuscular mechanic, and today I wanted to talk about ultrasound guided wrist joint injections. So, what might I use these for? Typically for wrist arthritis, and not so much osteoarthritis, but inflammatory arthropathies such as rheumatoid or crystalline arthropathies such as CPPD arthropathy. So, like my prior videos, when I go through an injection, I want to talk about a checklist that involves what the ideal patient position is, what transducer I should use, where to start with surface localization, structures I need to identify on pre-scan, and then how do I get after my target of interest. So, we'll go through this. With patient positioning, I will have the patient on their back supine with their arm by their side, with the forearm pronated such that the palm of their hand is flat on the table, and then I'll have their wrist flexed to bring out the joint. Because it's a superficial structure, I'm going to use a high frequency linear ultrasound probe to get the best resolution, ideally something with a small footprint. Then with surface localization, often, like particularly if there's not a lot of swelling, the person is sort of a thinner body habitus, you can really feel that soft spot where the joint is. Now, if that's not the case, what you can do is you can take your ultrasound probe and put it in short axis over the wrist, move it proximally until you identify Lister's tubercle, this prominence over the on the radius. Once you've identified that, then you can move your probe distally until the radius disappears. At that point, you're sort of at the level of the joint, and then you can rotate in long axis to better appreciate it. What I'll often have to do is then I'll translate the probe radially and often rotate it so that the overlying extensor digitorum communis or EDC tendons disappear. I don't want to bring my needle through those tendons. That will be painful. So I try to find that spot to the joint where they're not overlying. Then with my pre-scan, because we're going after the radioscaphoid joint, I need to identify the radius, I need to identify the scaphoid. Now, occasionally with the scaphoid, you're going to appreciate overlying hyaline cartilage, but bear in mind that if you're injecting into an arthritic wrist, that cartilage may not be apparent. And then with the injection, I want to bring my needle in plane. I'm basically injecting or bringing the needle in from distal to proximal, again, getting into the radioscaphoid joint. Now, this can be difficult to do in plane, so to make it easier to access the joint, I can do two things. I can use a gel standoff technique, or I can have the wrist flexed to make it easier to get into the joint space. And often you might need to use both methods. So now we're going to start. So I'm just going to sort of freeze there. So what I have is I have my ultrasound in short axis over the radius, and what I've identified as LT is Lister's tubercle. And so on the left of the screen is radial, on the right is more ulnar. So what I'm going to do shortly now is I'm going to move that ultrasound probe in short axis slightly more distally, and there my radius is disappearing, and there is my scaphoid. So now I'm sort of at the area of the joint, and what I'm going to do is I'm going to rotate that probe, keeping sort of the midpoint fixed 90 degrees so that I can see that joint in long axis. So here we go. It's going to be pretty quick. So there. So I'm going to pause here in a second, and there I go. So I have on the left of my screen the radius, on the right there the bony contour of the scaphoid, and then overlying it, you see this nice sort of fibrillar appearance of the EDC or extensor digitorum communis tendon. And so there's my joint. Now you can appreciate that at this level, I'd have to go through the EDC tendon to get to the joint, which might be uncomfortable. So what I'm going to do shortly is I'm going to take my ultrasound probe in long axis. I'm going to translate it slightly radially, and then I'm going to rotate it slightly. And you're going to see two things. The EDC tendon is going to sort of disappear, and the joint space is going to become more obvious. So there I have on the left, again, the bony contours of my radius. On the right, my scaphoid, and then overlying it, if you can just appreciate right a bit above the bone, is this black sort of line, which is my hyaline cartilage. And there is another picture of my radioscaphoid joint. And so there again, my radius, my scaphoid, and I'm bringing that needle in between the two. So you can see now I don't really have the overlying EDC tendon. If I feel it's difficult to get into this joint space, again, I might flex the wrist and use a gel standoff technique. And here I am just sort of, again, flexing the wrist and extending the wrist to sort of show the movement there. So that concludes the video today. I'm the neuromuscular mechanic, and I hope you found today's video series handy. Take care.